Ocular Inflammatory Disease Support Group, which is part of the Ocular Immunology and Uveitis Foundation. It's a 501(c)(3 non-for-profit, tax-exempt organization founded in 2005 by Dr. C. Stephen Foster. Our mission is to find cures for ocular inflammatory diseases, correct the worldwide deficit of properly trained ocular immunologists, and provide education and emotional support for those patients afflicted with ocular inflammatory disease. In addition to our support groups, which we have monthly, we have events for fundraising, for research at the foundation, and our support group events. So we have the Walk for Vision, which is in Boston this year. It's on Sunday, August 23rd. The other walk is in New York, New Jersey. It's actually in New Jersey at Verona Park, and that's going to be held on September 19th. You can go to uveitis.org and find out more information about that. And then every year we have a educational course. We call it the Ocular Inflammatory Disease Crash Course. We invite patients to attend that. We have a support group at that meeting. This year it will be in California in the Dana Point area on Saturday, October 24th. As I said, we offer support groups every month now. You can find out the whole year on uveitis.org, but our next one coming up will be April 14th, and that will be Ask a Patient, advocating for your best care. And then on March 12th, we have the Ocular Inflammatory Disease Research Updates and Emerging Therapies. As I said, I'm Frances Foster. I'm here as the support group facilitator. I provide a welcoming and supportive environment for us to share, learn, and connect with each other. I'll go over the ground rules for us that we follow during the meeting. So remember, we are a self-help group. We share stories and experiences to help each other cope better and live better with a chronic eye inflammatory condition. We focus our discussion on the present, thereby helping each other move forward in a positive way while living with our chronic illness. We do not offer medical advice unless we have a license to do so, and we don't ask that of the guest speaker either. We don't criticize any healthcare providers or past negative healthcare experiences. Again, we want to stay positive, focused on the present and the future and moving forward. I ask everybody to stay muted until it's your turn to speak during the question and answer session. And if by any chance we get Zoom bomb, please leave the meeting and then rejoin. And with that, I will introduce our speaker. We are privileged to have Dr. Mulkey. She is a graduate of the Damascus University School of Medicine, and having completed her postdoctoral training, whoops, I just lost my last slide, sorry, including 3 years with us at Mercy and under Dr. Foster. She did 3 years of ocular immunology and ocular inflammatory disease. She then decided to pursue her further training after her internal medicine as a rheumatologist and did a clinical fellowship in rheumatology at Beth Israel Deaconess. So she has the best of both worlds for her patients because she understands the eye ocular inflammatory disease plus the rheumatology systemic disease. And she is going to present to us the correlation between ocular inflammatory disease and systemic illness. And with that, I'm going to stop my sharing and I'm going to share the slides for Dr. Mulkey. Just give me 1 second to pull up her slides. Okay. All right, and with that, I'll pass it over to you.
All right. Thank you, Frances. Hello, everyone. I want to use today's presentation as a way for you to understand why is it very important to recognize ocular inflammatory diseases and what that might lead to in terms of other diagnoses. So hence my title, The Eye as a Window to the Rest of the Body. Next slide. So we're going to start with a case. We have a 42-year-old gentleman recently diagnosed with anterior uveitis by ophthalmology. He was found to be positive for HLA-B27. Upon further questioning, he reported to have chronic lower back pain, and as a result, he was referred to rheumatology for further evaluation. At the rheumatology office, he underwent X-ray of the pelvis that showed inflammation of the sacroiliac joint. He was ultimately diagnosed with ankylosing spondylitis and then went on to start treatment in collaboration between ophthalmology and rheumatology, and he did well. So this is just the X-ray that I was referring to. This is the pelvic X-ray here. We're looking at what we call the SI joint or the sacroiliac joint. The sacrum would be the central bone that you see, and then the iliac would be the pelvic bone that connect to the sacrum. And there are two joints on each side, and the arrow points toward the inflammation in these joints. Haziness in the X-ray usually represent inflammation in the area, and that's what we call sacroiliitis. And that's very typical finding in patients who may have what we call ankylosing spondylitis, something we're going to touch base upon as we move forward. So now what's so special about the eye? The eye shares several protein targets. We call those antigen. And in common with those in rheumatic diseases. Some examples are the hyaluronic acid, which is present in the joint fluid and also the eyes, type 2 collagen, and then lots of other proteins. Some of them named are proteoglycan, and they're present in the eyes and the joints. And then we also have this HLA-B27 association, which we kind of touch base upon. Next slide. So uveitis, as you may know, is divided depending on which part of the eye is affected. Starting with the anterior uveitis, which has to do with inflammation of the most anterior part of the eye, the anterior chamber and the iris, and what we call iritis. Then next. So what are some of the possibilities in patients who may have anterior uveitis? So a large proportion of this patient, we call them idiopathic, meaning we don't know why they have uveitis, and it's up to 40%. But then another larger group have another systemic association, and these are some of the examples. So the most common association with anterior uveitis is called HLA-B27 associated spondyloarthropathy, and it's ranged anywhere between 18 to 30% of patients with anterior uveitis. Next is a more rare disease, which we'll kind of briefly talk about. It's called sarcoidosis. And then we have Behçet disease, and then lupus, and then infections. I'm listing infections here today because it's very important to keep in mind as we're approaching these patients. It's not going to be the focus of today's discussion, but then important to keep in mind that infection can present as mimicking autoimmune disease, and it's very important to recognize because the treatment can differ radically. Now, focusing on the intermediate uveitis, which has to do with inflammation of the middle layer of the eye, or the specifically the vitreous, and then the ciliary body. The list of possibility in terms of association with systemic disease is not very long. So we have here multiple sclerosis, sarcoidosis, and then again infections. Next slide. Moving on to posterior uveitis, which has to do with inflammation of the back of the eye, and it can impact the vision pretty significantly. So here again, we have idiopathic, meaning we don't know why, and then we have sarcoidosis, Behçet, lupus, infection, and some of the masquerade like lymphoma, for example. And then panuveitis, which has to do with inflammation of the entire inner layer of the eyes. And then the list here is kind of very similar to the posterior uveitis list. So we have again idiopathic, and then we have spondyloarthropathy, sarcoidosis, Behçet, lupus, infection, and then some masquerade. Next slide. In the PEDS population, the list can be slightly different, and one very unique association we call juvenile idiopathic arthritis is very important to recognize because it's similar to the rheumatoid arthritis in the adult population, but then there are some certain characteristics that we look for in trying to assess the risk of having uveitis and how aggressive we should be in monitoring them and treating them. And then some other rare disease here like Kawasaki disease and tuberous sclerosis nephritis. Next slide. So you can see here there are some very common association across the different type of uveitis. And here we're talking about sarcoidosis, Behçet, lupus, spondyloarthropathy, and then lupus. And so we'll touch base upon these diseases. Next slide. So what are the HLA-B27 associated diseases? So it's a group of disease that can affect different part of the body. The most familiar disease is what we call ankylosing spondylitis, and this is, as you can see in the left upper corner of the slide, it is primarily affect the back, and patients present with chronic back pain. One thing to keep in mind is that back pain is one of the most common complaints in the primary care setting. So there are certain characteristics that we look for when assessing back pain and trying to decide whether or not these patients may have autoimmune disease. Example would be back pain of young onset, so below age of 45. Back pain that's typically present in the morning. Patient wake up feeling like we feel very stiff, we cannot move, and that gets better as the day progresses. And then they tend to respond well to non-steroidal like ibuprofen and Aleve. Now, the other disease that falls under HLA-B27 associated disease is called psoriatic arthritis, or click. And that has a unique association with a skin condition called psoriasis. So here you see the psoriasis plaque. And it's this distinct skin lesion that's red, little raised, can be very itchy and has scales. Some very characteristic association or typical distribution are the elbow sides. These are areas that we look for around the hairline, just like you see here. Can be also in the umbilicus and then the scalp sometime, and also the feet. And so when we see this, we think of psoriatic arthritis, and then the typical presentation is usually knee inflammation. So swollen knee, red, warm, hard to move knee. Now, the next disease is what we call enteropathic arthritis, which has to do, which presents as an association with inflammatory bowel disease. And the two most common ones are Crohn's and celiac disease. To the left middle in the slide, you see what's called reactive arthritis. And just like the name implies, it's reactive. So basically presents, usually patient may give you a story, they have some sort of urinary tract infection or GI infection within a month of their presentation. And it tends to have something unique that is, can remit on its own. So it can have some sort of like a monophasic presentation, patient present inflamed and then can go away. So they may not go on a long-term treatment. And then we have the juvenile spondyloarthropathy, which affect the teenage year around 16 and has one unique manifestation we call enthesitis, which has to do with inflammation of the tendon around the joints. And that's a very unique feature to this disease. Now, the last disease in this group is called undifferentiated spondyloarthropathy. So meaning they may have these presentation, but we don't have a clear association and we don't know why. So we call them undifferentiated. Next one. Sarcoidosis is a very interesting disease. It's very rare. It's less than 60 in 100,000, so very, very rare. And it has to do with the immune system dysregulation, trying to form what we call granulomas. So granuloma is a key word that we look for when we're trying to diagnose patients with sarcoidosis is on the biopsy. And it tends to affect different part of the body, starting with the eye with uveitis, and then also can lead to bigger lymph nodes. So patient may say, I have a lymph node that's in my neck. It's been there for a while. I don't know what it is. And then that's something we kind of try to assess and try to look why they may have that. Another disease manifestation is the lungs. So they may have also lymph node around in the chest area, and the lung tissue itself can be affected as well. The heart can be involved, the liver, the joint, of course, you were talking about the joints, especially the lower extremity joints, the knees and the ankles. And then it has a click. It has a unique skin manifestation we call erythema nodosum. And you see here these nodules that are usually present in the legs. They're usually painful and tender to touch. And this is a very unique feature to sarcoidosis. Next slide. This is another very rare disease, Behçet disease. It has to do with inflammation of the blood vessel. It tends to be present along the Silk Road, so from the Middle East through Asia. It's far more diagnosed in the Middle East, especially Turkey, and very rare here in the United States. Some disease manifestations are ulcers in the mouth and also the genital area. And then it has this kind of pustule-looking skin changes that you see here. And then also it can present with the erythema nodosum that we just talked about. So it's a lot of skin and mouth and mucosal disease. Next slide. Systemic lupus erythematosus is a very rare disease, not as rare as Behçet, but it's a kind of very heterogeneous disease that affects different part of the body. The main feature is what we call malar rash or butterfly rash. Here we see that this redness that goes across the cheeks. It also has a certain distinct feature that we look for. Basically, it should go across the nasal bridge and should not touch the nasal fold, we call it. So you see here this kind of clear triangle shape going across the nose. When it's more aggressive, it starts to affect other part of the body, and here we see how the rash is spreading all over. One unique feature that it's tend to be very photosensitive, meaning these patients can flare up around sun exposure. So one thing we caution them about is to try to stay away from sun as much as possible. Now, not only the skin can be affected by lupus, so it can affect also a different part of the body. The joint, also the layers around the lungs and the heart can be inflamed. And the belly can also can be inflamed. The layer that kind of coat the inside of the belly can be inflamed. And the most worrisome involvement if it starts to affect the kidney. And so it's very important to recognize this disease very early and start them on treatment, because some of these patients may end up with kidney failure and some of them may require kidney transplant. So it's very important to recognize this disease and start them on treatment early on. Next slide. Now, let's move on to scleritis. Scleritis is inflammation of the outermost layer of the eye. It's divided into anterior and posterior. Anterior represents the vast majority of cases of scleritis. It's divided into diffuse, nodular, and necrotizing. And then we have the posterior, which are a lot more rare. Click. So some of the association, one is, again, can be idiopathic. We don't know why. So between anywhere up to 50% of the cases, we don't know why. So not every patient presenting with scleritis can have a systemic association, but then a large proportion of these patients may have a disease association. And the most common one in this case is usually rheumatoid arthritis, which we'll talk about in anywhere between 10 to 18% of the cases. Now we have granulomatous with polyangiitis is the next on the list, and not as less common compared to rheumatoid arthritis and can be present anywhere between 4 to 8% of scleritis cases. And then we have more rare diseases we call relapsing polychondritis, which has to do with inflammation of the cartilage around the ears and the nose. And then we have SLE and then spondyloarthropathy. Next slide. So what is rheumatoid arthritis? Rheumatoid arthritis, by definition, is a disease that primarily affects the joint. It's known to be polyarthritic, meaning it affects multiple joints all at once. It can affect any joint in the body. It can be small, can be large joint, but it can affect many joints. The one unique feature that tend to be symmetric. So it has to usually patient present with joints of both sides involved. And the typical presentation is a joint inflammation of the hands. So a lot of time the small joints are affected, especially of the hands and feet. Click. And this is represent what hands could change to if this patient left untreated. So again, very important to recognize this disease early, start them on treatment, because continuous inflammation can lead to joint damage, can lead to change in shape, can lead to permanent changes that are irreversible if not went on treatment early on. Next slide. Now, the next is granulomatous polyangiitis. So this is one of our most scary disease. It has to do with inflammation of the blood vessel, and as you can imagine, blood vessels go everywhere. And so, if these blood vessels are inflamed, they can affect any part of the body, and some organs involved can lead to sometimes death. An example would be the lungs. These patients can sometimes bleed into their lungs, or they can also have a kidney problem and they can present with kidney failure. So recognizing this disease is very important to start them on treatment early on, and could be life-changing treatment. Click. And so it can affect different part of the body, the eye, we talked about the scleritis part, the lungs, the kidney, the heart, the skin, and then also the sinus and the nose. And so again, here it shows why it's very important to recognize the diagnosis of scleritis, and then which from there went on and we found that may have other diseases that's very important to treat and can be life-saving. And with that, I'll be happy to take questions.
Thank you, Lama. That was an excellent talk. I will stop sharing.